Welcome to Brainstorms, Functional Neuro Rehab for SLPs, a podcast presented by Speech Therapy PD. Brainstorms is designed for adult medical speech-language pathologists working across practice settings and across the lifespan. I hope that this podcast brings you evidence-based practice that's easily digestible and applicable to your everyday practice. Enjoy. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello and welcome everyone. My name is Renee Garrett and I am your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Benjamin Bennett owns the consulting business AAC Pathways. As an employee of the Escondido School District, he is a paid employee. And as a guest on this podcast, he receives an honorarium from Speech Therapy PD. His non-financial disclosure is that he is the California Speech Language Hearing Association District 9 Director. My financial disclosures are that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial compensation. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I am the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat box or the Q&A and will be answered throughout the presentation. Now, without further ado, we welcome our guest, Benjamin Bennett, MS, CCC-SLP, ATACP. Benjamin Bennett is the AAC Specialist at Escondido Union School District, EUSD, where he has worked for nearly a decade. He assesses and implements augmentative and alternative communication, or AAC systems, for students with complex communication needs. Benjamin provides training for parents and professionals on integrating AAC into daily life. Previously, he was a speech-language pathologist focusing on bilingual therapy for Spanish-English speakers. Benjamin serves as a San Diego County District Director on the California Speech Language Hearing Association Board and has delivered many professional development courses in AAC. He strives to simplify complex concepts to make AAC accessible and empowering for everyone involved. Passionate about helping AAC users reach their full potential, Benjamin is dedicated to breaking down stigmas and fostering resilience in the AAC community. Thanks for being here, Ben. So great to see you.
Yeah, likewise. Thanks for having me.
Yeah, of course. So let's just dive right in. I think a great place to start is always identifying how our communication partner training is so impactful for what we do, because I think a lot of times people forget that we're not only treating a communication disorder, a language disorder, a speech disorder, whatever the case may be, or different, as I like to call it, different ability. But, one of the primary roles that we have is education and communication partner training. So how would you say that that's sort of defined or integrated into what you do?
Well, I think communication partner training is something that, when I first started as an AAC specialist was not really on my radar. I think a lot of people, when they think of AAC, they think of the device, they think of choosing, how to assess for it, how to operate it. But what I found over the years was the more proficient the communication partners were with assisting the AAC user, whether that be with the device itself or with the strategies that happened to be required for an AAC user, the more successful that AAC user was. And so there's not really a consensus on communication partner training being a required part of the AAC treatment process, but amongst AAC sort of researchers and people really in the field, it pretty much is something that everyone encourages as much as possible. So the more of that's done, the better the outcomes. I mean, that's just really the easiest way to put it.
Yeah, no, I agree. And I'm thinking like strategy wise, kind of where do you start? Because we talked about this before,
Mhm.
I work mostly with adults, you've mostly worked with school age kids, but it doesn't matter because looking at AAC as a continuum across the lifespan, your communication partners will start in one space and maybe transition from parent to significant other or for even friends along the way, depending on where the AAC user travels across their journey, right? So,
Right.
kind of where do you start with training a communication partner?
Well, I think, I think it depends on the AAC user themselves. That everyone's got their own unique needs, of course. And I think normally I wouldn't begin with that caveat because the types of AAC users that I work with, I work in an elementary district that goes from pre-K to eighth grade. Generally, the ones that I work with tend to line up with their needs, but occasionally you'll get something more akin to what a person who works with adult AAC users might see more often, which is, an individual that has, a greater amount of metacognition, right? Greater self-awareness. So you really have to think about which end of the line the AAC user is in that respect, because if you're working with someone who's really on that other end that has more metacognition, then you really have to start thinking about what are the very specific things that you might want to train on. So, I'll kind of get into some waters that I'm not super comfortable in here, but if you have someone like an ALS user or an ALS patient who, as an AAC user, who may eventually need to start communicating with eye gaze, for example, then you're really going to have to start training the communication partner in the operation of the complex device that they have, and how to troubleshoot and things like that. And because usually these people are adults with lives and complex things that have to be done, or even someone like, to bring it back to my age group, someone with cerebral palsy,
Hmm.
who's maybe, even an elementary age, who has, typical cognition. You really need to train the communication partner more in things like the importance of pausing, where, when someone's composing a message, because it's, because of the emotional factor on the user, for example. But at the other end, which is who I tend to work with, the communication partners are generally the ones who look after the individual. And of course you have that in the adult population as well, maybe with like an intellectually disabled individual, maybe a group home, for example. Then you start to get into those really sort of typical strategies that I tend to push a lot. And those strategies tend to be the ones that I really, really push are having AAC available. It's not really a strategy necessarily,
Yeah. Well,
but
we
if
like
you
to think it's common sense, but it's not.
yeah, exactly. But if you push it like a strategy and you give lots of little tips, people tend to respond better to it in my experience. So, having for a child, I encourage images all over the house. And of course, you may want that for, again, for your adult patients as well. But I encourage, so the top three are always, having AAC always available. If they have a personal device as well, sometimes my AAC users don't have a personal device. It's more, low tech. But if they do, then having it charged and in the same spot every day, all day, when it's not being in use, when it's not in use. That's the first one. The second one being to model, and I think that's kind of universal, to be completely honest. I think modeling is something that you really want to make sure that aided language stimulation, aided language modeling, whatever you want to call it. That's the biggest one, in my opinion. And then I said three, but there's a few out there that I may really, really push, push out. And one of the other main ones is expected pausing, you know, waiting for longer than is comfortable, essentially. So those are some of the big three that I like to push out.
Yeah, and a couple things you said. I want to get back to low tech so we can kind of talk about that a little bit. But the expected pausing is really important because we see that a lot in our adult folks with aphasia. And I always describe it, and I steal this from my dentist because she calls it the treadmill minute. So it's like that last minute that you're on the treadmill is the longest one because you know you're almost done. And so I experienced this with the reason she brought it up was because during the pandemic, we were doing this whole different routine. When you go to the dentist, you had to rinse with like a solution you didn't normally do. And it was a full minute at first, and then they finally weaned it back to 30 seconds. But she would say it's like the treadmill minute. And almost choked on the solution that I'm trying to like swish in my mouth to make sure I'm all good to go. But it's very true with our patients with aphasia and other motor speech disorders as well. We encourage our communication partners to give them that wait time because what happens is most of the time people who are caregivers really they want to help and they want to jump in and they want to save and rescue and fix and repair. And a lot of times it's not necessary. It's just that extra 10 to 15 seconds that sometimes might be actually 45 seconds is
Yeah.
really helpful because then the patient can actually get their own message out. And I totally agree with what you're saying about that. So, you and I are looking at, and what we talked about before was across the lifespan, because I don't think that differs so much based on diagnosis versus sort of that familiarization and that ability to use the device and being trained appropriately. So, what do you feel like that user kind of pause and wait for the user is one thing, but for the communication partner or the communication supporter, what does that look like for them, whether it's a teacher or a parent or maybe it's a paraprofessional that's like their one-to-one aid.
Yeah, I think it's, it's when I do trainings for professionals and I tell them that they need to pause when they work with children, I get a lot of eye rolls, because they're trained to do that. But what I like to do in the when I do a training is I actually like to give them an exercise where they ask each other questions and they have to pause for a certain amount of time before the other person is allowed to answer. And sometimes I'll do 10, and sometimes I'll even go all the way to like 30 or 40 seconds. And the amount of discomfort that people have
Yes.
during that, even that 10-second pause it's pretty eye-opening. And so even to the professionals who know, even to the professionals who work with preschoolers who know they pause all day, but they may not pause for 10 seconds. They may think 2, 3, 4 seconds is a good pause, but for our AAC users who not only have, sometimes have cognitive concerns that, have to be processing, right? Extended processing, but also message creation. You may have to be waiting for a very long time for someone. And so, I'm very sympathetic when I talk about that with people and I say, I know that this is strange and uncomfortable and not natural, but let's try it and let's see what it feels like. Because I think, knowing and feeling are two completely different things, at least in that on that topic. So that's usually what I do is I'm pretty empathetic when it comes to people not being able to do it as a habit. And then but I do try and show them what it looks like. The other thing I've often recommended is for children and, perhaps for adults, but probably is more of a low cognition or a child-led activity is something called Follow the Car. And that's something that Project Core, I don't know if they developed it or they just pushed it out, but it's a shared reading strategy where that includes a series of pauses. So CAR stands for comment. I'm trying to remember what the A stands for. I don't know. It'll come to me maybe, but comment, ask, I think it's ask,
Yeah,
comment,
ask,
ask, respond. And
respond.
so essentially, if you're doing a shared reading book, you take the book out, you comment on what you see, you wait. If no one's responding, you ask a question. Oh, does anybody see the nose? You wait around, and then if somebody does give any sort of indication about communicating, then you respond. Oh, I think you just pointed to more, so I think you're telling me more. So you comment about what you're doing, you ask for participation, and then you respond if you receive any participation. And it's a pretty easy to remember framework that happens to include lots of pauses. So I do push that a lot if someone just can't wrap their head around it. I often use that with parents.
Yeah, no, I think that's a great strategy too for adults because a lot of times, again, the caregivers, they want to fix it, right? They want to
Yeah.
do that communicative repair, and they jump in, and they jump in, and you see the patient's face just sort of like it's like candle wax melting. It just drops because they had it and now it's gone, or they had it and they almost were there and then they can't get it out because someone started talking and they totally lost their train. And we see that too with a lot of our patients with dementia or
Mm.
patients with fluency disorders where they're trying to get I had a have a sweet and I say sweet, I shouldn't be, descriptive that way, but I have this he is the sweetest man with schizoaffective disorder, and he has a fluency disorder, and his family really wants to kind of fix that. But he's a lifelong stutter. He's in his
Mm.
60s. It's not going to change, and they've never had anyone approach it from a this is part of who he is standpoint. And I think they were stunned yet grateful, and grateful yet also stunned, if that makes any sense. And I think we see that too with our AAC users, where the care partners, no matter who that is, if it's parents, if it's guardians, if it's group home direct service providers, day support people, school paras, school teachers, whatever the case may be, we see that a lot, and that they really want to help and fix. So to insert those pauses are challenging and certainly something we feel like people should know, but they don't know. They don't.
Yeah.
It's just like with us, when we were in graduate school or even early career professionals, that active listening piece is really hard because we
Mm.
have all this knowledge and stuff in our heads that we want to help and fix and do the things. And it's really hard to actively listen to someone and actively take that step back. So I'm glad that you mentioned that because it's a huge piece of what we do.
Yeah, and I think that what one thing I wanted to add too is, you asked earlier what strategies that I like to incorporate. One of the things that I also like to emphasize, and you made me think about this when you were talking about fluency disorder, it just kind of popped in my head is, when I train speech pathologists, one of the things that I mention is a lot of speech pathologists, in my experience, most speech pathologists who work with AAC users maybe part-time, and it's not like their niche area or something they're really into, don't do a lot of communication partner training. And I think that's really, I don't know. I don't know what it is. I think it's a lot of reasons, but one thing I've found is that it's really a confidence issue. And one thing that I like to really emphasize is, we have so much expertise. And I at one of my presentations, I researched all the things that, I made a big list of all the things that we have to know to graduate. And it's a pretty damn big list, and then I said, and you guys know all this, and all you need to do is tell somebody how to pause and how to, keep their child's device available, or their, loved one's device available, or or model, right? Modeling is maybe the most complex of the three, but it's still not that complex. And so I think that confidence is, I think it should be looked at in a different way. I think, I think it should be turned up on its head a little bit. And because I think that a lot of us are confident in our areas, right? If we're really into, maybe fluency or speech sound production or whatever. But the things that really assist with AAC users in terms of teaching the communication partner strategies are so simple. They're just so simple to relay. So I think that, just giving it a shot, just trying communication partner training and seeing if it is something that is difficult, which it probably won't be, but seeing if it is, it's something that I always encourage people to do. I said, worst case scenario, you've lost, half an hour to an hour of your time and may not decide to do it again, but I think usually that's not the case.
Yeah, and I think again across the lifespan and across disorders, we tend to automatically sort of incorporate this into what we're doing anyway. We just don't realize sometimes that's what it is, especially if you are less seasoned clinician. You come out of school and you're thinking about how well, it may be not everybody, but I know for me, like I was a caregiver before I was a speech language pathologist. And so one of the things that was really important to me was always providing the diagnosis, the education piece, and how the communication partner could be helpful. And I see it a lot in other clinicians who maybe haven't had that same experience. So I think it has to do with the drive and the naturalness of kind of jumping into the profession.
Mm-hmm.
But again, realizing that we get this hyper focus on AAC devices, right? But we don't realize all these other pieces that are AAC things. So things like visual age or visual. I'm gonna lose my train. Visual aids. Kind of articulate my words. Texting on the phone, reading a recipe,
Yeah.
all these things that we don't think of as AAC, but we learned that we have low tech, we have mid tech, we have higher tech stuff. And so I think you mentioned pictures all over the house. So kind of talk us through communication partner training and like why that, what do you mean by pictures all over the house?
Yeah, so one of the things that well, two things. So I'll go from like a parent and a professional angle. So for for parents, what I'll generally do is I will tell them, listen, you just want at the very least, a lot of times parents are really, they're new, they're scared, they're hesitant. And so I'll just say, listen, here's some core boards. Just put these up around the house. Put them on the fridge, put them on the door, have one in the car, and we'll do the same at school. And so, your child has access to, the same sort of vocabulary no matter where they are. That's kind of a bare minimum that I like to do. But for the parents that are really interested and involved, I'll go a little bit further and I'll say, listen, like you should have pictures of things that they like all over the house. So if they have certain foods or drinks that they like, put it on the fridge instead of just having them open the fridge, grab it, and then going back to the table. Because you do see that quite a bit in young children who are nonverbal, that the parents just kind of, they don't know what they want. They don't know how to, get them what they want. And so they just let them sort of free roam around the house. And I think, there's a lot of reasons for that, no judgment whatsoever. But what I try and get them to do is at least have that sort of symbolic way of communicating in different areas. And so, sort of bridging to how I speak to professionals, that's how I always speak to professionals, is I say, okay, what you need to do is you need to have the symbols that are used for the activity at that activity. And, in addition to all the core boards and all of the, all the other things that need to be around the room. So, I worked with a teacher last year, for example, she and I were looking around the room trying to figure out what symbols would go in different places. And it didn't even occur to me. One of the things was the trash can, and so the trash can had put and in, like core symbols next to it, for example, and on the door, go, in, out, all those basic symbols. And so for child learning language for the first time, that's certainly effective. But for some of the other like more phrase-based communicators, and this is something that you're probably going to see more of in maybe an aphasia patient, for example, maybe dementia, I emphasize maybe not symbols, because that individual may not be symbolic for the children, but even an adult person may respond, even an adult patient may respond better to photographs over symbols,
Mhm.
to have, again, photographs of things that they require, throughout
Mhm.
throughout the house, and not necessarily a book or anything like that, but really in those strategic places, because, most often than not, the AAC user is not, especially if they're at home, they're not going to be carrying their personal communication device, whatever that looks like, around with them. It's just not going to happen. It's going to be on the table or in their room or in the backpack, unfortunately, but it does happen more often than not, I think. So yeah, having them readily available in the places that they're going to be needed goes a long way.
Yeah, and it's funny because that's one of the things that we kind of talked about was I have an adult 30-something-year-old right now that has autism and verbal apraxia. He had childhood apraxia of speech and now it's, they're terming it verbal apraxia, but he is verbal. But there are times when he's difficult to understand to unfamiliar communication partners. And so one of the things that he's really great at is picking out logos. So he loves to go. His mom gets so frustrated because she blames it on his dad, but he loves to go get food at like Subway. And there's
Mm.
a couple of local restaurants he likes to go to, but he recognizes the logo. So when he sees that Subway logo, he knows that he can just point to it or like pop it up on mom's phone and show it to his dad. And then his dad's like, "Oh, Subway, you want to go to Subway, buddy? Let's go." And he's like, all excited about it. And his mom gets so frustrated because she's like, "He doesn't need to eat that. He's 30 something years old." But it's good because it's a great example of how we're not scaffolding language for a patient like that or client like that. He's not trying to learn how to syntactically create this message. He's just learning, or he's just communicating this one thing he needs or he wants, right? And that's the bottom line, is not
Right.
necessarily creating this construct of language, but getting that immediate need across. And so that's kind of one of the things that we talked about before we recorded tonight, was that it's kind of been cool to see the metamorphosis of the AAC systems, even the ones that are high tech, because originally they really weren't all that high tech. They were very layered. There's a lot of menu hierarchies that you had to go through to get your message across. And now, for those folks that are needing that more immediate conversation or that more immediate need, and that's all they have is that immediate thing that they want, they're able to do that in some sort of more intuitive ways and more user friendly ways. And so it kind of leads me to barriers for AAC access and training, because what I see is with the adult patients who maybe have autism or have an intellectual disability, what I see is that maybe they were exposed, or their caregiver was exposed to this older model of this
Mm.
hierarchical system of language access. And so they're very put off by a higher tech device. So, what would you say are kind of those barriers now for the AAC access and training?
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Yeah, I do see that a lot. I see a lot of professionals and even parents who have interacted with those professionals over the years. want, only realizing that, for example, like PECS is the only option, right? I get that quite a bit. And so essentially what I try and do is, when I do, when I do a lot of training, I essentially, I try and emphasize the fact that a prosthesis. And, I talk a lot of, so when I talk about AAC being available all the time, for example, I do a lot of comparisons with other disabilities. And I say, someone with a hearing aid is, or someone with a hearing impairment is not going to go without their hearing aid for very long, at least not functionally. Someone with a visual impairment, they're going to need that walking cane, when they're crossing the street or just all the time. So a person with AAC really needs visual communication. And that's really what I try and do in terms of barriers. And I do see lots of barriers because, you know, just to be blunt, I think for parents, it's something that's kind of weird, right? Like having, or anyone, it doesn't have to be a parent, but I think it's something that's not going to, it's something that's brand new often for the caregiver. And I've tried, for example, I've tried showing videos of proficient AAC users, and sometimes that backfires, right? Because they see someone with cerebral palsy who can't speak and communicates through a tablet, and they're like, that's not what I want. And so what I try and do is I really try and focus on the fact that communication is communication, whether it's verbal or any other mode, gestural. But what AAC users really require is visual communication. And so just breaking it down like that is usually fairly successful for the buy-in. But in terms of resistance, or well, we tried PECS and it didn't work, so now we're just trying to see, we just want them to speak. I get that a lot. I usually just say, well, listen, like, do you ever send memes on your phone? Do you ever text? Do you ever email? And I try and emphasize that, we're all AAC users in a way. And so we just need to give our kids what's going to work for them. And, so just breaking it down into something that's a little bit more basic, like, it's a way to communicate visually. And if they do communicate verbally one day, they're not going to go back. Verbal communication is by far the most efficient way to communicate. And, as soon as someone figures out how to do that for a particular concept, they stick with it. So, but
yeah,
I mean, it's a AAC buy-in or resistance. It's a pretty big topic in the AAC community, but those are some of the things that I've tried.
Yeah, and I think we all have said that staff meeting could have been an email, right? I think that's kind of the point that you make, is that once someone is able to do that verbal communication, and I think, again, this is something that we talked about before. I had a patient with spastic dysarthria that we knew he had a brainstem midbrain stroke, and he had some of the worst palatal, laryngeal, pharyngeal myoclonus I've ever seen. His ENT said the exact same thing, and they did try some Botox injections. And so the goal was to have the AAC device as a supplemental communication thing for him, or access method for him, for when he struggled with someone he didn't know or someone who didn't know him. But what happened was, one of the barriers was he didn't want to use it. He wanted to communicate verbally as best he could, but it also became sort of, not the device itself was a joke, but like he had a personality that he just had a great sense of humor. And so one of his defense mechanisms was joking, his sense of humor. And so he wanted to have a like country old man voice on his device, and his wife joked around about how she thought it would be, and I'm going to use her word, sexy, if he was the Australian male version. And we had so many like laughs about it, because we had to laugh about it and go with his sense of humor, because really he was the driving force His wife could push him all day long, but ultimately he decided that for him, it wasn't what he wanted, but the two things he wanted was to use a sense of humor. And his programmable device, his quick fires, he wanted them all to be curse words. And that was part of, again, his defense mechanism. And so we kind of just had to go with that. But while it was funny and like also gratifying to see him sort of embrace that side to try to get a sense of humor so he wouldn't be super depressed about his situation, it was a barrier to implementing a device in totality because it wasn't what he wanted ultimately. So
Right.
I think that is a big barrier, is looking at, again, it doesn't matter if it's a kid, school age kid, adolescent, teenager, grown up, adult, if they don't want to use it, they're not going to.
Yeah, and that's, I mean, you touched on a couple things that I've come across quite often, and the first is that when you do have someone who is verbal, a lot of times AAC is it's the first line of defense, right? If someone's maybe unintelligible or even selective mutism, it's definitely something that people think of pretty quickly. And I've definitely gotten mixed results because like we mentioned, verbal communication really is the most efficient. And if someone is able to communicate verbally, the motivation to use a different mode of communication is usually not high. And so, I mean, I've certainly tried a number of different things, and I think it really comes down to finding that motivating factor for the individual. I haven't found like a really great approach that this works, most of the time or 90% of the time. But those are usually the most difficult cases to work with are the ones where, they just want to speak because it's so easy to do so, but people, but it's not effective. And something I've tried recently that's been having more success is when an individual is semi literate, to have a more text-based system which uses prediction. And even if a child or even if an individual can, I'm going to say child and student probably the whole time. That's just what I do all day.
It's fun.
But even if they can't, even if they're not wonderful spellers or they can't even compose full sentences, being able to start a word with a communication partner usually has a lot of success. So if someone's trying to talk about, McDonald's, they probably know the M. And if they know the C, then you can usually say Mick, okay, and you can get pretty close to that. So that's actually been really, really useful. And there's a lot of systems out there that do it natively, and some that are specifically designed for that. And then the other thing I was thinking that you were talking about that made me think of was user buy-in for AAC when it comes to customizing their own device. And that's something I often kind of have to gently express to caregivers and professionals that it's really important that we allow the AAC user to have the device in the way that they want it, even if they're saying, fart butt, or whatever, like if that's what they want to say, that's what they're going to say verbally or on their AAC device. So let's manage that in a different way. Or even, I've had kids choose all sorts of different voices for their systems. And a lot of times they choose the weird, the, what do you call it? The novelty voices.
Yes.
But that's what they want. And if that's what they want, and that's going to motivate them to communicate, and they want the kids around them to laugh when they say something, then great, let's do it.
Yeah, still communication. That's the goal.
That's right. So not everyone sees it eye to eye, but it's usually not a big deal. So.
Well, and that was one of the barriers, I think, for me, was earlier on, and even with this one particular client who recognizes logos for restaurants. his mom, and it's happened before with other clients. His mom was like, we've tried these devices and they all sound like robots. And so it's
Mhm.
so oftentimes for the adult populations who are, needing a device, not because they had an acute event. So they didn't have a stroke that caused aphasia, or a TBI that caused aphasia, or a new onset progressive neurological disease. So sometimes we get clients that are intellectually disabled their entire life, and they went through the school system and they got a device, and it's now in 2024, they might have had a device in 2014
Mhm.
that was very different than what we have access to now. And so their parents, or even sometimes guardians, were used to this very robotic sounding language output, and they hated it, and it wasn't motivating for the client because it was startling. Sometimes it was hard for them to the client themselves to process this robotic sounding device that, even if they could verbally communicate, they may not have ever heard their own voice, but they've heard voices of people around them, and it still sounded nothing like that. So for
Yeah.
me, that's been one of the challenges, is trying to get past that, just to even trial devices with adult clients who are still under the guardianship of their parents,
Mhm.
or guardians who've been their guardians since they were, younger, because they've only ever heard that. And once they left the school system, they really weren't receiving any kind of services. And that's the only thing they knew. So when I bring up devices, they're like, what? No.
Yeah. Yeah. I mean, and I would say, I would argue they're still not supernatural to this day. They're a lot better than they used to be, no doubt. But the good news is, if you look at some companies like 11 Labs, they've come up with some really amazing, I don't know what the term is for it, to be honest, because it's not really my area, but just natural intonation. And the good news is that's coming. I don't
Mhm.
know how long, and some people say in the next year, and I think I heard that a year ago. Some people say 5, 10 years down the road, but I think that is something that will be a thing of the past, that, the synthesized speech is not very natural. And, I think if anyone's ever done like the AI chatting with voice, I think ChatGPT and what's it called? Google Gemini, they do it as well. It's you can certainly tell that it's not quite a human, but it's hard to tell. And so I think
Mhm.
when the AAC industry catches up to integrating some of that technology, then that won't really be an issue anymore, hopefully. But I think there will always be older AAC systems with synthesized voice. And I don't know if there's a funny story about Stephen Hawking, who, Microsoft developed his system, and after I don't know how many years of using the system, they came to him and they said, "Hey, like we've got this we know a lot more than we used to, and we'd love to upgrade your system, and we'd love to give you a really great sounding voice. What do you think?" And he said essentially, "No, I'm good. I like this is my voice. I like it." And he's like, "I don't care if I sound like a robot, because that's who I am." And I may be getting that story wrong. It may be myth. I may be paraphrasing, but at the end of the day, I think a lot of people feel that way, like, robot or, or human, like this is who I am. So,
Yeah. Well, we certainly can't knock him. He revolutionized for everybody that comes next. And I think just looking at even things like acapella, where you can voice bank for patients with
right.
diseases that are progressive, sometimes people are hesitant when they first get a diagnosis, like a progressive neurological PPA, or they're sometimes hesitant, and it takes a little bit of time to convince them to do voice banking. But then it's like you really have to work hard at, again, realizing, or trying to figure out how you access the communication partner, because often they're the key in doing something like voice banking, because it's an acceptance thing for a lot of clients and patients to, they're grieving this diagnosis, and they're like, I don't want to do this, but then they don't realize the time frame that we're looking at, as far as it may not be there 6 months from now, it may not be there 8 months from now or a year from now or what have you. It's something that sometimes is fleeting depending on the diagnosis. And so it is cool that we have access to that, but it is, again, it's like a catch 22, right? It's like what came first, the chicken or the egg? We've got to figure out how do we get this going, because we know it'll help you, but then they have to have that buy-in.
Yeah, and I mean, and speaking of voice banking, it's interesting you mentioned that because, iOS now has or has had for a few years now, native voice banking baked right into the software. So, or the operating system. So you can actually, I think it's called personal voice. I can't remember
Mm-hmm.
exactly what it's called. And so even for someone who may not be able to afford voice banking, or, doesn't really want to go through all those steps, if they have an iPhone or an iPad, they can start, they can start right away, even just to test the waters. Because I don't think it takes that long. I think it takes about 15-20 minutes to put your own voice on there. So it's a pretty, yeah, it's becoming a very cool, common thing for people to be able to do. So I think that's an interesting new thing for AAC users. And I've actually had a few users who've done voice banking for like their sibling. And so they'll have, I want my sister's voice. And so okay, great, no problem. We'll just get your sister to say a couple things, and that'll be your voice. So, that's definitely a kind of a nice thing that's available really widely. I remember just a few years ago, voice banking was, one of those things that only a select few kind of did, because it was something that, for primarily for maybe people with ALS who knew that it was coming and they wanted to preserve it, for the future. But nowadays it's not ubiquitous yet, but it's certainly all over the place.
Yeah, because then it wasn't always accessible because a lot of it was insurance driven. And as we see with a lot of things that we do, which is super unfortunate, but just, looking at strategies for SLPs to kind of overcome a lot of these barriers, I think is another great place to land, because I think what I see is that a lot of SLPs are very, very hesitant to dive into AAC, especially if it's not their niche. But you know, we especially when you're treating adults with progressive or just any neurological communication disorder, we know that they may have a need for AAC immediately or in the future. And so I think not knowing is not an excuse. And I think people use that a lot is, oh, but I'm not the AAC specialist. But
Right.
what we now have with a lot of these companies is SLPs who are the AAC specialists who are employed to be that person. And I don't think when I first came out of school, I don't remember, I feel like it was more salesperson-y. Like if you called PRC or you called
Right.
Lingua Systems back in the day, it was more of a salesperson who might have basic stuff for communication. But now, what by and large, across different companies, we have a lot of SLPs who have experience who are now these AAC people. So can you kind of talk about, because I can talk about it, but I want you to talk. Can
Yeah.
talk about like what they do, what do they offer across different companies?
Well, I don't work a lot with reps because the way that our particular district works, we have pretty much in-house funding for devices, but I do on occasion. And the first thing that I would say is I have noticed in the past probably 4 or 5 years, I've noticed a shift in the sort of the messaging from companies to appeal to the communication partners for training and AAC strategies. And it's not quite where I would like to see it, of course. In fact, I still think it's more of an exception to the rule, but I have certainly noticed a shift, and I think that's a huge positive step. The other thing I would say is, of all of the companies that I work with locally, and I'm in Southern California at least, all the reps are SLPs. And so I think that's a pretty cool shift in the way it used to be. And like you said, it did used to be primarily, salespeople, and you still get that, of course. I'll call a company and ask, if they could talk to me a little bit about, what their approach is and things like that. And then I'll just, get a sales pitch for their device. And I'm like, oh, okay. But by and large, the fact that there a lot of SLPs out there is good. And I know they do training both individually as well as publicly.
Yeah, well, and
Yeah.
a lot of webinars on their websites.
Yep. And it's almost always free, which is huge. And so I think ultimately that's a good thing, and it's gotten a lot better over the years. But I still would love to see it go further, to be completely honest. Um, and I would love to see that as just part of an SLP's toolkit, or I think I just violated copyright, SLP's toolbox. But no, I really would. I think that's something that we really should focus on. And even I remember one thing that was really effective for me when I worked just as a general SLP in the school system, when I would work with preschoolers. It was effective when the parents would come into the therapy session with me. And I think some people like that, some people don't. But I always loved it because, what really worked was I would just talk through what I was doing with the parent. And that's something that I found really effective. And so I would love to see that sort of concept shifted over to AAC users, and have the SLP be the primary point person, because I think that it is nice that companies are doing that nowadays, and they do have a lot of resources to sort of distribute that. But at the end of the day, the real scale, I think, comes from the SLPs themselves, who, work with, maybe 5, 10, maybe more AAC users, and they're the ones that, are going to really have the closest relationship with the families, and can really tailor whatever strategies need to be provided to those individuals. So yeah, I think that's but for the companies themselves, I have certainly noticed a good shift in the right direction, if I might, be so opinionated.
Yeah, you can be opinionated. It's fine. So if you were, I don't want to say fresh out of school because that's not accurate.
Mhm.
If you were someone who maybe hadn't had a lot of AAC training or a lot of reason to provide AAC as an overall resource, and I'm not talking about low tech, let's say more mid to high, let's go high tech. If you
Mhm.
were an SLP who really just had not had that experience, what are some things that you might suggest, like ways to get started?
Well, I think it kind of depends on your work setting, of course, but I think that one of the things I would do is to go to either a rep, or I think every state is legally mandated to have an exchange. So find that exchange, find the rep, and borrow some devices, and play around with them. I know I'm really advocating communication partner training, but you were asking about high-tech devices, but I think that you can't have one and not the other. So
Yeah,
I
for
think
sure.
one of the things, there is a big stigma, or lack of buy-in, or maybe fear, whatever you want to call it, about the complexity of a high-tech device. So, having it in your hands, playing around with it, doing more hands-on things, I've found is really important, and effective for, kind of, calming those nerves, so to speak. And then, in terms of just looping back around just to communication partner training, and maybe someone recently out of grad school, I think that, just finding some basic training. And I mean, if anyone here wants one, I'm happy to provide one, right? If they just wanted to email me, I'm sure, I presume my email's in the show notes, but to, just find one and just try it out, try to give it, see how it goes. And it's probably not nearly as difficult as you think. So I think those are the two bits of advice I would give to, a fairly new clinician is, get your hands on it, try it out, find an AAC user, and if you don't have one, you will probably. And yeah, just try to give the parent or the communication partner, depending on, who your client is, see what you can figure out to train them and see how hard it is. And because it's actually really, really easy.
Yeah, in Virginia, we have TTAC, so training and technical assistance, and it's actually the university that you and I went to have it, but other universities within Virginia have it, but I don't know what that's called in other places. Is it
Right.
called the same thing in other, like, I know you were in Chicago for a bit, now you're in California. Is it TTAC or is it something else?
It's not TTAC in California. I can't remember the name of the exchange, to be 100% honest. I don't use them that often.
It's
But
usually through a university, right?
uh, it's usually not necessarily. I mean, I want to say I want to say the Department of Ed has mandated that the
Okay.
Department of Ed, or
Mm-hmm.
I'm not sure. Again, I got to go back and remember this, but I think every state must have some sort of exchange. And I think in California, it's kind of a collection of entities that work together under a single like we have a website.
Mm-hmm.
And so I've ordered things. Obviously, it's easier to order locally. I know United Cerebral Palsy has a lot.
Mm-hmm.
They have a lot of sites out there, but I've ordered things from as far up as Northern California, up in the Bay Area, all the way down here, just because that's what they had, what I was looking for. So yeah, I'm not really sure exactly what it's called here, but
Somebody said ability tools.
Yes,
Ability tools.
Thank you.
Okay.
Thank you very much.
Thanks,
Yeah.
Crystal.
But yeah, every state has one, if I'm not mistaken.
Yeah, I was thinking the same thing, but I knew for us it was TTAC, and again, the nice thing about it for us was that we were exposed as well. I mean, I went for undergrad, so undergrad and grad school, I was exposed to that, and they're still like, they typically, at least in Virginia, they typically will have, whether it's someone who's a trained educator, but I had a friend who's an OT that I actually grew up with who worked at TTAC for a very long time, so she was looking at not only the communication aspect, but the access methods. And so often what you'll find is it's not just some person, I hate to say off the street, but like a lay person. They're not just running a library. They are trained in this specific thing, and they know how, like, if you contact them, they know how to connect you to the thing it is that you are looking for, even if you don't know what it's called. But a lot of it is not only linking you to the resource, but is linking you to the resource that will help your communication partner be empowered. So I think that for me is a really great place to start, because it's something that everyone can utilize. That's super helpful and kind of makes it less intimidating and less scary, if you will.
Yeah.
Well, Ben, I really thank you for being willing to share your expertise and letting me pester you to come on the podcast. So just full disclosure, Ben and I actually went to graduate school together, and I harassed him to be I didn't really harass him, I'm kidding. But it's just really cool to see what you've been able to accomplish and like where you're at in your career. So I appreciate you being willing to share and come on and relate things across the lifespan, and not just from your perspective of working primarily in the schools and being able to translate that for the audience. So I appreciate that.
Yeah, of course. It's been a pleasure. It's been nice chatting with you and seeing where we've all ended up, and hopefully we can do it again sometime.
Absolutely. Absolutely. Thank you again. We look forward to seeing you again. Thank you for joining us for this episode of Brainstorms, Functional Neuro Rehab for SLPs. We have a special coupon code for our listeners to receive $20 off any annual subscription to Speech Therapy PD. Head over there to get ASHA CEUs for listening to this podcast and all other episodes. The code is Brainstorms20. 20 is the number 20. We appreciate your positive reviews and support, and would love you to write a quick review. Also, subscribe. If there's a topic you'd like to see us cover in the future, you can email us or comment in the comments section or message us on social media. Remember to go to Speech Therapy PD to learn more about earning ASHA CEUs for this episode and more.